Good evening, friends. Once again, I welcome you all on behalf of Lokmanya Tilak Medical College, Sion Hospital. Under the IAP action plan, we are conducting these postgraduate clinics, and we are very thankful to Vocard Vaccines for the generous grant for this academic event. Dr. Reshma, please come.
Thank you, sir. Myself Reshma Nevgi. I would like to start with my case. My patient Santosh Yadav, 9 months old male, second by birth order, born out of non-consanguineous marriage, Hindu by religion, Yadav by community, residing at Kurla, hailing from UP, brought by informant being mother, came with complaints of fever since 7 days, cough since 3 days, cough and cold since 3 days, and increased respiratory activity since 1 day. Patient was apparently alright 7 days back when he had fever, acute onset, moderate to high grade, intermittent, not associated with rigors or rash, responding to medications, and the child was active during interfebrile period. Cough was dry, non-spasmodic, not associated with post-stressive vomiting, no diurnal variation or no diurnal or postural variation. Cold in the form of runny nose. Breathlessness in the form of increased rate of respiration. No history of noisy breathing or ear discharge. No history of recurrent respiratory complaints on which the patient was treated on OPD basis. No history of suck cycle or increased sweating during feeding. No history of increased precordial activity noticed by the mother. No history of swelling over feet. No history of bluish discoloration of skin. No family history of any asthma or allergy. No history of tuberculosis or tuberculosis contact. No history of any congenital heart disease in the family. No history of regurgitation of food. No history of suggestive of foreign body aspiration. History of failure to gain weight in the last few months, and no history of decreased feeding or decreased activity. In past history, patient was admitted at 5 months of age with complaint of convulsion, which is generalized tonic-clonic with uprolling of eyeballs, for which a lumbar puncture was done, which was apparently normal, and the child was suspected to have some metabolic cause and discharged on calcium medicines. So probably the cause of convulsion was some hypocalcemic convulsion. Birth history. Mother was 29 years of age when she antenatally registered at Muktabai Hospital, received supplements, TT injections. USG was done at 5th and 9th month of gestation, which was normal. No antenatal complications. Full-term normal vaginal delivery. In hospital, baby cried immediately after birth. Birth weight was 1.75 kg. Breastfeeding was started on day 1 of life. On day 2 of life, child was admitted in NICU in view of jaundice, which required phototherapy and IV medications. The child was discharged on day 17 of life, and the mother was told that the child is having some syndromic abnormalities, most probably Down syndrome. Immunization. The child is immunized till 14 weeks according to the national immunization schedule. No special vaccines are given. Developmentally, on gross motor, head holding at 6 months, rolling over at 7 months, which comes to developmental quotient of around 55%. Fine motor, Bridestus reached by 6 months, palmar grasp by 9 months, which accounts to about 66% of developmental quotient. Social smile at 6 months and stranger anxiety at 8 months, 88%. Language, the child is only able to speak gu words and cannot speak monosyllable or bisyllable, accounts to about 33%. Hearing, child responds to sound, vision, eye contact is present and it looks at bright objects. Dietary wise, the child was exclusively breastfed for first 6 months. Weaning was started at 7 months of age. The child is fed only cow's milk and biscuits at present, which accounts to around 500 kilocalories, deficit of 300 kilocalories. Proteins about 6 gram, deficit of about 6 gram. In social history, the mother is 30 years old, uneducated, and she's housewife. Father is 40 years old, uneducated, and works as a painter, earns around 7,000 per month. 5 people stay together in a pakka house which is on rent, which has common toilet and water supply. According to the Kuppuswamy, they come under upper-lower class.
Okay, so let's start analyzing the history. So who will take up the chief complaints and tell us what do they mean? The age of the baby today is?
9 months.
9 months. So chief complaints are fever, cough, breathlessness, right? So how will you analyze that? What she described, would you analyze that or would you want to ask any more questions? Come on. We've discussed fever, cough, breathlessness few times in the past, so it shouldn't be difficult. Come on. Attempt, somebody attempt. So we have a 9-month-old baby who's just now come with fever for 7 days, cough for 3 days, and breathlessness for
1 day.
1 day. And at 5 months, this baby had a afebrile seizure, and on day 2 of life had jaundice, for which needed NICU treatment, and was discharged on day 17, and born about 1.75 kg. So come on, fever, cough, breathlessness, this kind of a story. What do you think?
It started with fever, so would like to know exactly how the fever was and
She gave all that details. So the fever was not very high. It was responsive to medication, interfebrile normal. All those details were given.
So it started with fever, then the cough came, and then the breathlessness. So it could be lower respiratory in origin, and
Yeah, so I mean, we've discussed this many times in the past that what is the order of symptoms when you are suspecting or expecting a lower respiratory tract infection? Fever is the first sign of an infection. But then in a usual classical lower respiratory infection, does cough come first or breathlessness come first?
breathlessness comes first.
So here she said cough on day 3 and then breathlessness on day 7 of fever. So we want to just discuss that when is this possible, or what are the thoughts that cross your mind. So a child who started with fever on day 1, why should this child become breathless on day 7? What are the possibilities? Is it a bacterial pneumonia which is making the child breathless on day 7?
Sir, it could be that the child was breathless before and the mother noticed that when the child had actually having severe breathlessness and the mother noticed it just a day prior.
Or it could have been viral. It could have been only mild infection initially, which would have aggravated to cause breathlessness later on.
So which means you are saying that this is a viral infection where the child has become breathless. So it's a viral interstitial pneumonia type of a thing.
With superadded infections later on.
So two different possibilities. One is that a viral infection has become a pneumonia or is a viral pneumonia. And second is secondary bacterial infection on a initial viral process. So there are two different issues. Now, any takes on that? Any thought processes on that? So let me ask you pointed questions. Take a viral infection. Viral infection starts with fever today. Usually when does a viral infection start coughing? Usually. Immediately, almost simultaneously with fever. Sometimes there is a prodrome of cough cold, otherwise within a day or two. So usually there will not be a gap of 3-4 days. And the cough is a very bad and a predominant symptom. Okay. So breathlessness coming up on day 7 is also little odd for even a viral thing. And what about secondary bacterial infection?
Sir, also fever lasts for 7 days. It is unusual for the viral infection.
Okay.
So it is in favor of bacterial infection, and it is acute in onset, and your child is not sick looking.
Okay. What about secondary bacterial infection? Let's discuss when do you get secondary bacterial infection on a primary viral infection in pediatrics? Is it very common?
As the child is suffering from also hypotonia, so this may be possibility.
Hypotonia?
I think she told the head liking up also again.
No, head lag is a, she talked of delayed milestones. So this child has delayed development. But on history, how will you judge that this child is hypotonic? Anyway, go on.
Anyway, aspiration can lead to further aggravation of breathlessness.
Okay, so in aspiration, you were saying that the child aspirated later.
Definitely.
So how will you pick that up clinically? How will you pick up clinically aspiration? Choking episode and acute worsening of cough. Okay, so that's your key to aspiration. Okay, any child who's aspirated has to cough very badly. Okay, okay. So come back to secondary bacterial infection, because I want all of us to go home with a clear concept in mind. How common is secondary bacterial infection on viral infections in pediatrics? Viral infections are so common, no? So do we get secondary bacterial infection time and again? No. So why? So when will we get, or when should we think?
Immunocompromised?
Immunocompromised, and as such is this baby is preterm and low birth weight.
No, it's full term.
Full term and low birth weight, sorry. And weight is 1.75 kg and kept in NSA for 7 days, suspecting bronchopulmonary dysplasia. BPD is one of the reason. It may cause a recurrent respiratory tract infection.
See, first of all, there is no history of recurrent respiratory infection. This is...
So there was a history of recurrent respiratory complaints but treated on OPD basis.
Okay. I think bronchopulmonary dysplasia is a separate topic. Let's not get into that. What I was trying to say, to cut the long story short, is that secondary bacterial infection is not common. So unless there is, the host is abnormal, so you said immunocompromised or a malnourished child, or the virus is very, very strong, that means a measles. So a child getting measles and post-measles, you may get a secondary bacterial infection. So that's an example. But for routine viruses, there's no secondary bacterial infection. So let's not take home that. Yeah? Okay. Okay, so we were on the order. So I think we've discussed this many times in the past. So when a child has cough and then it is followed a little later by breathlessness, this is often a alerting point to you that the cough means airway involvement. Airway involvement initially and then breathlessness. This is not the order of infection, so this often suggests a cardiac origin. So this cough is probably stimulated by pulmonary edema type of a situation and then breathlessness. So remember that when this order comes in, you must think a cardiac origin. So that's a possibility. Okay.
I was just making a point that get details of fever. Was the fever high all throughout? If that is so, take it as infection till proved otherwise. If the fever was just a symptom, and go into details and they said, no, sometimes we used to give paracetamol in a day or two, then that's a different story. Any inflammation causes fever. So allergic inflammation also may cause fever. Auto-inflammatory disorders cause fever, but depends on what's the severity of inflammation. Acute infections generally have high fever. This going on for 7 days, you said fever. What kind of fever has gone on for 7 days? Is it a high fever where every 4-6 hours you require to give paracetamol? Oh, I am still thinking of an infection. Where infection will come to that. On the other hand, if you give a story, 7 days fever, but sometimes it was there, sometimes it was not there, then I take myself away from infection primarily. Second thing is that, was this child treated for those 7 days before you saw him? Has somebody been giving an antibiotic and some drugs, and the problem is just getting different than what a standard progress of an illness is? So unless we know all that, we won't know that. But the point is well made again, that how severe was the cough? Cough is just mild cough or a severe cough. That's important for us to know. If the cough is severe, it is an airway involvement. If the cough is mild, it could be parenchyma, it could be upper respiratory, it could be anything. Unless we know all these details, we won't know. She made a point that breathlessness may have been there and was observed later. Yes, possible. Why don't you ask the history to fish out that there was a subclinical breathlessness that parents missed? How would you have made out at that? Was there a feeding difficulty? A cardiac child has a feeding difficulty because it's not an acute breathlessness. Respiratory is often an acute breathlessness. Acute pneumonia is acute breathlessness. Acute bronchiolitis is acute breathlessness. Cardiac, generally subacute or chronic breathlessness. So her point is right. Breathlessness became evident to the parents. But what about you asking the history? Was the baby irritable, not feeding well? Would have meant that the child was really not probably all normal. Breathlessness didn't start all of a sudden. Cardiac breathlessness rarely starts all of a sudden. The respiratory breathlessness comes in a short time, 1, 2, 3, 4 days. This seems to have taken a long period. That's why we start wondering about that. But if we say it's a cardiac disease, then why is he running fever for 7 days? Which cardiac problem runs fever for 7 days? That also looks little unusual. So I think we are not very clear what is happening. Looks like it's not simply a respiratory disease, but it doesn't fit in also cardiac disease. So the point is, do we have a combination of the two? What's the combination of the two? Here is a child who gets recurrent respiratory infection anywhere. Now he also has a heart disease, so he is behaving differently. And he's not behaving like a typical respiratory nor a typical cardiac. Might give us an impression that this child has got a dual lesion. What is dual lesion then? Does a child of a left to right shunt not also have repeated respiratory problem? He comes with a respiratory infection and also gets worse in his cardiac status. Yeah, that's possible. So this must be a kind of a shunt operating with a recurrent respiratory problem. This time the infection was severe, further worsened a cardiac status which was not so bad, but respiratory infection worsened it to cause more breathless. He was always little breathless, now more breathless. You treat respiratory infection, that breathlessness will come down to base level breathlessness. I think that would be the way to go about. Lastly, if this child is getting repeated respiratory infection, say, then what's the growth like? What's the development like? I want this child not to be growing well, if our hypothesis is right. But if you say, no, he is growing very well, then I think we are going wrong somewhere. Same way development. His cognition may be all right, but his motor milestones must be delayed. So he's not yet turning over. He just started holding it now, which will give me an idea that he has already a chronic disease, which seems to be coming with recurrent respiratory problem, which has worsened now for some reason or the other. Lastly, I would also bring in whether this child has got a bacterial endocarditis. After all, he has got a heart disease. If you say he's high fever, spiking high, very sick child, I might paint a picture of a bacterial endocarditis as well. So I think these are all options.
The growth which sir said will be complicated here by two things. One is we know that this baby was born small, and second, we've been given a dietary inadequacy history as well. So there'll be three contributors to poor growth. These two plus the illness, if the illness.
I thought you said he had a seizure at 5 months.
Yes, sir.
What's that seizure like?
Yeah, so
Let's bring in a seizure also.
So now let's discuss that seizure.
Now we must bring in seizure in a cardiorespiratory problem. Don't bring anything else. Cardiorespiratory problem has a seizure much before cardiorespiratory problem manifests.
So that's important to be discussed. 5-month-old baby comes with a seizure and it's an afebrile seizure, right? So what are your thoughts? Is it common
for a 5-month-old to get afebrile seizure? Forget cardiorespiratory story just now. Just discuss 5-month-old child afebrile first seizure. What must be that?
So discuss pros and cons or for and against, whatever thoughts come to your mind. What could be the
On this
cause
mic.
of this kind
You have
of...
a mic, yeah. Come on, start talking. Anyone?
Mic, hold it close to you.
A cyanotic heart disease, they can cause a cerebral abscess, and it can cause.
But we haven't got a history of a cyanotic heart as yet. No, for example, first take up only 5-month-old with a febrile seizure.
So first take a detailed history whether it's a seizure or a non-seizure event.
Very good.
Then if it is a seizure, then go ahead further and find out the cause. Maybe hypoxia may be the cause in this case.
No, so at 5 months. So for we are talking of a 5-month baby coming to us with a seizure. How will we start thinking?
So it could be any.
Come.
So we'll have to find out. So we'll have to find out if there is any preceding vomiting or diarrhea is there associated at that time, which may have led to the event.
Yeah, this child has come with first seizure without any symptoms. So he has no fever, no diarrhea, no vomiting, nothing. He just seizure.
Sir, first
Hypocalcemic.
Hypocalcemic. So who must be this candidate who gets hypocalcemic? You're right.
If the mother has not taken calcium supplements during pregnancy and the child is inadequately not fed properly and all.
So but why at 5 months then? Why not at 1 month?
Should we not seizure earlier? You're right. I would have been happy if he came at 2 and 3 months. But 5 months, yes, your point is well taken. But something more, he should be growing fast. Okay, combination of his mother not having enough vitamin D, and here is a child who is growing fast, that combination. If this child was not growing fast, then that is out.
Okay, any other situation where a borderline child is tipped into a metabolic seizure? Some event which tips a child who is otherwise borderline.
Sir, any weaning food items which are started, if baby is allergic, he is not able to tolerate, then in those conditions also seizure can occur. Fructose intolerance.
Okay.
Sir, introduction of some fructose diet can trigger off suddenly.
Okay, anything else? She wants to talk.
Phenylketonuria.
Well, okay. So what happens when a baby becomes breathless? Besides hypoxia, metabolically any derangement?
Metabolic.
See, sir wants to know what tips you into a hypocalcemic convulsion. Okay.
So baby suddenly became breathless or whatever, and then that changed metabolically, and what was otherwise a borderline status got tipped into hypocalcemia.
If 5-month-old came with a seizure without anything, your first question, was it with encephalopathy or without? If it was without, only 2 causes, hypocalcemia or a congenital malformation. If it was encephalopathy, it was infection, okay, it was immune mediated, it was hypoglycemia or anything else, metabolic. So if this was without encephalopathy, you are only largely concerned too. Okay. Now hypocalcemia, yes. If he was not growing well, less likely. 5 months, little less likely. And therefore must be congenital malformation. He has already one malformation. Oh, wonderful. He has another malformation. So that 5-month-old, if we did not know he had a heart problem, okay, we would have still said hypocalcemia or a malformation. If you had malformation in mind, we would have asked for a detailed milestones. And if his milestones were normal, we would have said hypocalcemia more likely. If his milestones were delayed, we would have said malformation. If his head circumference was small, we would have said malformation. Okay, so I think that's the way we would have gone on seizure.
Okay, and you said a lumbar puncture was done at 5 months, no? So what is your comment on that? So I think sir has already answered that you should have they should have taken a history And if there was no encephalopathy, then I wonder why a lumbar puncture was needed at that age, especially when it was a afebrile seizure for the cause of the seizure, right? Okay. Now, yeah, you asked a lot of negative history. So can we just quickly go over that? And I also want to know, you asked a lot of cardiac negative history. So what prompted you to ask that?
So the chief complaints of fever, cough and breathlessness wanted to rule out either respiratory cause or cardiac cause.
Okay, so which brings me that your previous history of repeated respiratory complaints. Now again we have made this point so often that if all those previous complaints were associated with fever as a predominant symptom, then it is repeated infections. But if it is not fever as a predominant symptom, then it need not be infections. So that has to be clarified. Okay? Okay, okay, okay. Fine. Negative history?
No history of noisy breathing or ear discharge. No history of recurrent respiratory tract illness complaints associated with fever. No history of suck-rest suck cycle or increased sweating during feeding. No history of increased precordial activity noticed by the mother. No history of swelling over feet. And no history of bluish discoloration of skin.
Okay. Then?
No history of any, no family history of any allergy or asthma. No history of tuberculosis or tuberculosis contact. No history of any congenital heart disease in the family. No history suggestive of any foreign body aspiration. No history.
One sec. Why did you ask this?
So because she had fever since 7 days and cough since 3 days and breathlessness just since 1 day. So if at all there could be a foreign body aspiration that could have led to the breathlessness.
So what is the typical history of a foreign body? Very acute, sudden onset of cough, and then fever will be followed much later after it gets secondarily infected. Okay, so the order of symptoms will be totally different. Chief complaint will be cough and not fever. Okay, go on.
And no history of regurgitation of food.
So why did you ask that? So you mean this baby has never regurgitated? That's very hard to believe, no? Every 100 out of 100 babies regurgitate. So what I wanted to drive at is that, when you say no history of regurgitation of food, it sort of hits the examiner that this is not the way to put it. Now, if you wanted to ask for GER, what would you have asked?
Regurgitation followed by these symptoms or choking.
Again, he's asking you about GERD. Not just gastroesophageal reflux. He's asking you about gastroesophageal reflux disease.
In other words, suppose this baby had history of regurgitation, then did it mean that you would think of GERD in this child as a cause of recurrent all these problems? So what I'm trying to say is, when will you think of GERD as a problem?
When reflux is associated with symptoms like failure to gain weight, repeated vomiting, choking, and opisthotonous posturing, these and recurrent infections, then we think that this reflux is pathological GERD.
Okay, very good. And along with that, what they also describe as this baby has aversion or refuse. Means this baby does not like feeding or does not, so it's very difficult to feed. So all this plus that is GER. Okay. Whereas just regurgitation can be what we call as a happy spitter. Right. So just regurgitation is not the bottom line. You need to look for all that. Okay. Go on.
So we'll start with the
Yeah.
exam.
So, okay. So what do we have on history finally? What do you think?
So it's a 9-month-old male child with history of fever, cough, breathlessness, with a history of prolonged neonatal jaundice and recurrent respiratory complaints, mostly lower respiratory tract infection in a syndromic child.
Okay. Come, we'll get the baby. Syndromic because the doctor in the newborn period told the parents that there is some syndrome. Otherwise, on the history, there was nothing. Any volunteers to examine the baby? Chalo, come. Those who are just itching and waiting to pass should come.
Meanwhile, just say that, is it a cyanotic heart or a cyanotic heart you are looking at?
The history of recurrent infections and absence of cyanosis history points towards a cyanotic. We are dealing with a cyanotic heart disease with feeding difficulties also present. So
Presentation of cyanosis could be late, so we cannot decide, cyanotic or cyanotic. As far as there is no history of suck cycle and sweating on forehead while feeding, so doesn't fit in a cyanotic heart disease. Could be cyanotic or cyanotic.
Name a cyanotic heart disease which presents with recurrent respiratory infection.
Increased
And the cyanosis may not have been noticed by that.
cyanotic heart disease with increased pulmonary blood flow like TGA or persistent truncus or single ventricle, sir.
I'm asking about 7-month-old whose parents have not noticed cyanosis, so we believe it's a mild cyanosis and still has a recurrent respiratory
So
infection.
TGA with VSD with
The
PS
total
can
anomalous
present as
pulmonary venous return and could be truncus arteriosus.
TGA with VSD can present, sir, like this. Mother may not notice the cyanosis because it's not so prominent cyanosis in those conditions.
TAPVC.
Yeah. Sure, you are also right, but commonest is the TAPVC or a PVPVC. Okay, it will exactly present like an ASD or a bronchiolitis, and you would even miss the cardiac condition. So we will, but as you said, likely that it's a cyanotic. A shunt or no shunt? Shunt. Why?
Most commonly is VSD we deal with, or PDA VSD.
No. Question is, from this history, why do you think that there is likely to be a shunt?
Sir,
Which shunt we don't know, but why there is a shunt?
Recurrent infections.
Because recurrent respiratory infection is there, so it will be like because of shunt.
So it has to be a shunt. Okay. Now, why did this child never got breathless earlier? You said no suck cycle. I don't think it's a cardiac disease.
Because it could be mild anatomical lesion.
Therefore, suck cycle is an impending failure, not a presence of heart disease. So this child has not gone into cardiac failure, but the respiratory infection has tipped into some breathlessness. And typical suck cycle is an exertional dyspnea, which means slowly worsening. This child did not worsen slowly. This child got a respiratory infection which complicated a pre-existing heart defect and therefore got breathless. So here is a cardiac disease without suck cycle. Whereas a typical gradually worsening heart defect is a suck cycle, exertional dyspnea. This was not exertional dyspnea. Let's call it a respiratory infection induced dyspnea. That is the difference. And what is suck cycle? Slowly progressive exertional dyspnea. This is not slowly progressive. This is acute onset respiratory infection induced. So here is a cardiac disease without suck cycle. Yeah. So nobody wants to come for exam. Exam is around the corner. November is almost approached. So you all must come here. Yes. Come hold the mic also. Hold the mic. Here is a mic for you.
कॉलर माइक है क्या?
Child is irritable and crying.
आप थोड़ा सा एक मिनट रुक. इनको इधर बिठाऊं? चलेगा इधर? हाँ मैम थोड़ा इधर बैठेंगे ये कुर्सी पे.
Child is irritable and crying. Before she was comfortably lying in mother's lap, but as I was approached to examine, she has started crying. I'm here to
With preferably tongue in thumb sucking position, and with some pallor present, with upward slanting palpebral fissure, flat faces, flat nasal breeze, and looks small.
These frontal boozing, dysmorphic features are there. Depressed nasal bridge and hypertelorism, and small dysplastic ear and low set ears, bilateral low set ears. She looks moderate pillar. Umbilical protrusion is there, and no abdominal distension, no edema, no icterus, no cyanosis.
Just get on one side so that he can. Yeah, that. Yeah.
And I thought frontal bossing is not correct to say. See, prominent forehead and frontal bossing, don't mix it up. When this point is very prominent, that is called bossing. So
There's hyperpigmented knuckles and hyperpigmented knuckles present, and no simian crease obviously, and there is short fingers. Apart from that, gap between first and second toe is increased, and most likely sandal gap is there.
No simian crease.
And some mild breathlessness present in form of
okay, can you tell us the anthropometry?
AF is wide open, around 3 centimeter. 3 centimeter in length. And pulsatile.
So weight is 5.8 kg, it is less than third standard deviation. Length is 66 centimeters, less than third standard deviation. Weight for length is less than -3 standard deviation. Head circumference is 41.2, which is equal to -3 standard deviation, but appropriate for the length. Chest circumference is 41 centimeter and mid-arm circumference is 12 centimeter. So the child comes into severe acute malnutrition according to the WHO standard growth charts.
What about general examination? They have missed any findings?
So the child is right now conscious, comfortable in the mother's lap. Heart rate, it's a vitals. Heart rate is 130 per minute regular. All peripheral pulses are well felt, good volume, no radial or radiofemoral delay, and carotids are bilaterally equal. Respiratory rate is 48 per minute abdominothoracic with subcostal intercostal retractions. Blood pressure is 81 by 60 by 81 by 68 by 60, which comes to 50th percentile. Saturation was 96% of O2. Pallor is present, no icterus, cyanosis, edema, clubbing or lymphadenopathy. Sir, I go to head to toe.
No, so have they missed any findings?
No, sir.
Tushar, we'll call this grade, malnutrition, WHO classification, all that is always a bit.
It's very difficult.
You're sure weight for height is less than -3?
Rajesh, if you are talking about Down syndrome, then we cannot use the standard charts to compare. That's the first statement.
Right.
So we need to use Down syndrome charts to say whether it is falling behind the standards of Down syndrome. Plus, if you have a child who is just at 9 months with 1.7 kg birth weight, rather than comparing them on a growth chart, we should look at how many months have passed and what is the weight gain, and comment on nutrition on that.
Correct. I also thought those points were important. So instead of just blindly using WHO growth charts, make a statement that this is a Downs baby and this baby was born 1.7. So I will go by my general observations. And my observation, I don't know about weight for height being less than -3, but my observation was that if the length of this child is 66 centimeters, then that roughly corresponds to a normal 6-month-old baby. And for a normal 6-month-old baby, 5.8 is little low, but considering that she was 1.7, it's not so bad. And similarly,
9 months.
Sorry. No, baby is 9 months. I'm saying we're saying weight for height. So the height age of this baby is 6 months. So for the height age of 6 months, a baby who was born 1.7 is now 5.6 or something. It's not so bad, not less than -3 standard deviations. Okay.
And I think make a habit of even a clinical examination of nutritional deficiency. You feel that on weight or height or something he is malnourished and severely malnourished, but he has a subcutaneous fat all over, then I think look at it differently. After all, if here you knew the birth weight, but suppose you did not know, even then you would have guessed that this child does not look severely malnourished. Look at his subcutaneous fat, look at his muscle mass. If that does not correspond to what your anthropometric measurements say, then you guess that he must have started low. Here is the situation where 1.7 has become 5.6 or 8, which means he has gone up by 4 kilos. 4 kilos in 9 months is not too bad. Okay, even to a normal child. Okay, well, he could have been 5 kilos, but just 4 and 5 doesn't make a difference. And same thing, the length too. So besides many issues which are made, Downs cannot be compared in the same growth chart. 1.7 fellow cannot be compared in the same growth chart. But even then, without knowing the past story, you could have guessed that this child doesn't look malnourished, so he must have been small to start with. That, I think that is the point. That also tells me that his heart is not so bad, because he has not done badly. Okay, that means his heart defect is well compensated, but the respiratory infection is coming in his way. And I think so much we can derive just out of those measurements. Yeah. Tell us the finding, because child is very irritable, so we won't bother the child. Yeah.
Anterior in skull, anterior fontanelle is widely open, 3 into 2.5 centimeter pulsatile. Posterior fontanelle is closed. Faces, flat faces, upward slanted palpebral fissure present, pallor present, epicanthal fold, hypertelorism. No brush field spots present on the iris. Low set ears and small ears are present. Flat nasal bridge, protruding tongue and open mouth. No teeth. Neck, there is no skin folds at the nape of the neck. No simian crease, clinodectally or brachydectally. BCG scar is present. Thorax, no short sternum. Abdomen, the umbilicus is slightly everted, but there is no umbilical hernia. Lower limbs, no sandal gap. Genitals, normal male genitals, bilateral testes are descended. Spine is normal. There is a mongoloid spot on the lower back. The skin is dry. In systemic examination, Respiratory system. On inspection, respiratory rate is 48 per minute. Abdominal thoracic with subcostal intercostal retractions. Shape of the chest appears normal. Respiratory movements are bilaterally symmetrical. No obvious deformity is noted. Trail sign is negative. Respiratory apex impulse is not visible. No scars, sinuses or visible veins. On palpation, findings of the inspection are confirmed. Chest expansion is symmetrical. Trachea is central. Apex beat is located in the left intercostal space just medial to the midclavicular line. On percussion, the percussion is resonant except over liver and cardiac dullness. On auscultation, the child is having air entry is bilaterally equal with rhonchi and creps on the right mammary, inframammary and infraaxillary areas. Central nervous system examination, higher functions, the child is conscious and alert. Cranial nerves appear, all cranial nerves appear normal. In motor examination, the bulk of the muscle appears normal. The child in supine position lies in the frog-like posture. Tone is decreased in all four limbs. Power is about more than 3/5 in all four limbs. Superficial reflexes are present. Plantars are extensors. In deep reflexes, all the reflexes are normal except knee jerk, which is brisk. Sensory system appears normal. No signs of meningeal irritation. No cerebral signs. Central nervous system, heart sounds are normal. No murmur is heard. Per abdomen, soft, non-tender. Liver is 3 cm, soft below the right costal margin, rounded borders and smooth surface. Liver span is 7 cm. Spleen is not palpable. No free fluid in the abdomen.
You heard the child cry?
Yes, sir.
Did you hear the child cry? Did you all hear the child cry? What is that? When he was quiet, there was no noise. But when he started crying, he had that noise. So what is that? Is it common with Downs? Yeah, laryngomalacia is common. No? You can have a little bit of laryngoesophageal reflux also. It's a known thing. Okay, and while examining, what I thought is, if I could add, sir, that midline defects, no, when you're talking about general examination, go through all the midline defects. One midline problem, all midline defects. Okay, and also you can pick up syndromes from features, from dysmorphology. So if this was Holt-Oram syndrome, what do you get? So if you have a Hrithik Roshan type of hand, you pick up an ASD there. Fine. Now if it is Pierre-Robin, so looking at the features, you can get a rough idea of what it is. Marfanoid. So what cardiac defect would you expect? A mitral valve prolapse.
One person at a time, please. Sorry.
So
one
there is
person at a time.
laxity, so you can have a mitral valve prolapse. And heterotaxic defects. So in examination, very important for you to speak about the liver and the spleen and heterotaxic defects. They are known with immune deficiencies. So a particular facial feature can give you a lot of hints. That has to be done. And if the mother says my child is deaf and if there is deafness in the family and sudden death, any cardiac defect? Yeah, those children have to be investigated. ECG has to be taken. The prolonged QT syndromes, Gerveldi-Lange syndrome and the other one. Okay, those potassium channel has to be done. And Turner is another one that you can pick up.
So what's your final diagnosis after examination?
It's a case of lower respiratory tract infection, most probably bronchiolitis, with global developmental delay in a malnourished child with hypotonia with phenotypic features of Down syndrome.
Okay, how will you investigate this child?
So first of all, I would like to investigate for his...
आप ले जाइए, ले लीजिए.
So first of all, I would like to investigate for
just one point. We said in a history cardiac defect. Okay, on examination we don't find. Why don't find? There is no murmur, that's it. So tell me murmur-less heart defects. Still my heart defect. Because my history told me heart defect. So how can I just say no, okay, no heart defect? No. Murmur-less heart defect.
So a small shunt is active.
Raise your hand and ask for the mic.
TGA with VST without pulmonary stenosis. Or trigastric atresia can also present without murmur. EAP we see also.
So AST also, small AST can't be having a murmur.
Sir, asking if it was a left to right shunt and you didn't get a murmur, what are you thinking of? Sir, just asking you if you had a left suspicion of left to right shunt on your history, and when you examined there was no murmur. And what are you thinking
the
of?
size of the shunt is small.
Eisenmenger syndrome.
Yeah, so one situation is reversal of shunt, but when there is reversal of shunt, what happens to the history also?
Worsening of symptoms.
One sec, one person at a time.
Worsening of the symptoms.
Worsening of what?
Sir, improvement.
But there was no cyanosis.
Improvement of the symptoms which are associated with increased pulmonary blood flow and worsening of cyanosis.
So symptoms which were attributed to increased pulmonary blood flow, like repeated respiratory tract infections, or if there is precordial activity or suck or whatever, those will seem to improve, but the child is not doing well. The child is still looking sicker or not doing well. And appearance of cyanosis is later. Okay, so that's the order. First, improvement of those symptoms or reduction in frequency, but child not doing well, reduction of signs, and then later maybe cyanosis. Okay, so that's the pattern.
What I wanted to say is that when there is no murmur in a heart disease, then both the chambers are almost equal pressure. When does that happen? One, because there is an extreme large defects and therefore no murmur. But these children are very, very sick, like a large VST or almost no septum at all. They are large. Or there is a ASD, because as such the pressure difference are so mild that a mild defect will be unnoticed. Though if you carefully see, probably you will still pick up a murmur, but it could be easily missed. Look at the natural course of a VST. Okay, as the VSD gets worse and a pulmonary hypertension starts developing, the child's clinical murmur starts disappearing and the child starts getting worse. So that's a classical example what he's saying before a reversal occurs. ASD is another example where the pressure difference are so small and a mild lesion could be easily missed. So I think that is what it is. Lastly, if there is no murmur, obviously there is no cardiomegaly of significance. All dilated hearts tend to have a regurgitant murmurs. So we conclude that this child has no cardiomegaly and no murmur, which means because this is Downs, we will search for an abnormality, but clinically we don't find any, right?
Endocardial cushion defect can present without murmur.
Absolutely. Okay. And then probably the commonest with the Down syndrome. So as what Sridhar said, some association would make you almost suspect that murmur. Even if you didn't have sign, you would say, no, I look for that. Yeah.
So how will you investigate this?
Now, just one more question. You said that the look suggests a mongoloid feature. Tell me which mongoloid feature look does not have a mongolism. So don't say mongoloid feature, so now is the Downs. Okay. You get my point? Looks mongoloid, but it's not a Downs.
So which feature does that mongoloid feature, that name is derived from which feature?
Upward slanting, apicanthal fold.
Palpable fissure.
So the slant of the eyes is called the mongoloid slant or the mongoloid feature because people from Mongolia normally have that kind of a slant. That's why,
Yeah.
right?
So my next question is, how do you know that he is from not that region? You haven't asked him. You just blame him for Downs. So what clinical findings tell you that he is a Downs? You get my question? Mongoloid feature makes you suspect down.
Hypotonia, sir.
Hypotonia. Okay, even at birth. That puts me to another question. Tell me hypotonic newborns. Yeah. Suppose the newborn has hypotonia. One is down. What other thing?
Hypothyroidism, birth asphyxia, any sepsis child, any congenital muscular myopathy, cerebellar.
Don't forget medications in the mother and the baby is being delivered by LSCS, especially the diazepam group.
Okay.
So first we'll work up for his acute condition. We do a CBC and a chest X-ray as is presented with respiratory complaints. Then as an overall, we'll work up for a Down syndrome. So first we would like to prove that the child is Down. So we would like to do a karyotyping. Then system-wise workup. We'll do a 2D echo for CVS, cardiac abnormalities. Then GI abnormalities. Will do a USG and
So which GI abnormalities and USG will show which?
Sir, they generally, so starting from the oral cavity, they will have delayed dentition. They could have laryngomalacia. They could have duodenal atresia, annular pancreas.
But are you looking for those on USG now? Duodenal atresia you are looking for?
No, sir.
Hypertrophic pyloric stenosis.
Now at 9 months in this baby.
Heart susceptible kidney and heart sprung be can rule it.
So what I'm trying to say is USG will pick up which GI abnormalities in this baby at this stage, 9 months. I don't think any.
There's no hypertrophic pyloric stenosis.
Yeah.
It's more acquired now. It's no longer congenital. In fact, if you take a macrolide in the first year of life, you can get acquired pyloric stenosis. Even mother taking a macrolide during her pregnancy, you can get a pyloric stenosis in the baby. I don't think you should include that in the Downs.
Okay, go on.
So then hematological abnormalities, we'll do a CBC and we'll look for the peripheral smear. Then hypothyroid, we'll do a thyroid function test.
Hearing.
So opthal examination and ENT evaluation.
How will you manage this baby?
So first I would like to counsel the mother about what the child is suffering from.
So should we practice counseling or?
But 2-3 questions before that. Suppose chromosomal analysis is normal in this child, then?
You do fish, sir.
Louder.
Fish will go for, sir.
So we'll do a fish analysis. Why?
Mosaic will show.
So we need to rule out a translocation 21-21, which is important for the next pregnancy because it is 100%.
So one is that there may not be trisomy, but there will be a dislocation. Okay, translocation. Suppose I look for that also.
So mosaicism.
So then mosaicism. Okay, unless all cells, see if you're strongly suspecting, you will look at more cells. Okay, mosaics are known, especially if he has an atypical features, not fully developed. Okay, he could be a mosaic. And apparently it may be reported as a normal chromosomal thing. So one may have to keep all that in mind, right? Will you do an EEG on this child?
EEG we will not do, sir, at present.
Why? I was saying congenital malformation as one possibility. I couldn't get a focal lesion, then I'll do a CT or MR. I'll do all that.
Congenital malformation can be picked by MRI or the neuroimaging, but EEG, some seizure or any other manifestation should be present.
So before MRI or CT, EEG is easy. EEG is cost effective. I'll pick up. After all, there was a seizure. So
One episode only, sir. It could be some predisposing condition might be present due to that.
I just had one more question. Once this is discussed.
I'm sure, you want to say something.
Congenital malformation will be deteriorating progressively.
Why? Congenital malformation doesn't deteriorate, it's a static condition. Why should it deteriorate? No, malformation doesn't deteriorate.
Sir, the CNS wise, the clinical symptoms will be progressive in case of congenital malformation. Just one seizure and then child alright won't be there.
No, but see, congenital malformation, what all do you expect? One is delayed development, which this child has, and recurrent seizures. So the recurrence may happen in future, no?
Sir, I am 100% sure this child does not get EEG, because even if EEG comes normal in case of seizure disorder, so and after doing EEG, as child is not having symptoms, that is not needed because of child is asymptomatic.
So you think EEG will not guide your management? That's what you say. Yeah, I think you could have said that this is a generalized seizure. So possibly, what are the problems with Downs then? Downs that do not have a localized abnormalities, they have a generalized disorder. Okay, so we are not looking at a focal thing, that's number one. Second is that we have done this in the past at our clinics, that when do you do an EEG? When you expect some epileptic syndromes that you can pick up by an EEG. So that's one possibility. Second is, if you are not sure whether it is the focal that went into generalization, okay, suppose there was a Todd's paralysis. Oh, you know it was a focal seizure, even if they said there was a generalized seizure, because then that's a focality. So I will certainly look at that. Third situation is, I have a seizure with neurocutaneous markers. I will like to do a EEG. In absence of that, your answer would be yes. I'll wait. Okay, I'll take a decision later. Just now, as you all said, that EEG will not help me to do that. But that puts me to the next question. Would you give an anticonvulsant? This child has got an abnormal brain and an abnormal brain seizuring. Would you give an anticonvulsant? Long-term.
Sir, we have to weigh the benefits versus risks. Sir, in this case, if we give an anticonvulsant now, it will give more of a side effect. It won't help in any way because there is no recurrence of the problem, and there is not any epileptogenic focus in which we'll give anticonvulsant, and it will help. It won't help in way. It will cause more of a harm only.
Would you agree that an abnormal brain has a high chance of recurrence?
Sir,
so this child has got a high chance of recurrence.
Though there is there, sir.
Why don't you stop recurrence?
But it will have a more of side effects giving continuous anticonvulsants where we have only just one episode of a seizure.
I am worried about status developing. What side effect? Total effect. So how do you convince me?
First, it was a non-encephalopathic seizure, and other is even if we give anti-epileptic, it will not prevent the epileptogenesis. It will only treat the episode of that seizure.
So we can give in that case the midazolam spray. We can advise to the mother if suppose in case if there are features which we can tell, and then we'll tell the mother to give in emergency.
Your answer would be that this is not yet an epilepsy. So why are we discussing anti-epileptic drugs? What is epilepsy? Recurrent seizures. Okay, so all that you know that this child may have a chance of a recurrence, but it has not proved to be an epileptic. And we are presuming that therefore he may get another episode. So you are right. You tell the parents and counsel them in case of seizure, how would they control, and if so, then come back to you to take a decision on whether that. Epilepsy is a recurrent seizure. And for recurrent, at least 2, ideally 3. Okay, but one is not an epilepsy. So it's clear that we will not give an anticonvulsant at this point of time. But yes, anticipate maybe. But the frequency may be so low. Suppose this child is to get once in 3 years. You will give anticonvulsant for 3 years and then slowly taper or stop, and then you will get another one. So there is no point in hurrying through to take that decision, right? Could
Tushar,
this have
any questions, Tushar? No?
No, nothing.
Okay.
Now, at 9 years, he throws a convulsion again, and you take him up for an LP. Any precautions to be taken? So any contact sports or this thing, he has to be assessed for an atlantoaxial. Then there was a mention about mongoloid spot. Is it a benign lesion? It's not a benign lesion any longer. It is linked with, it is definitely linked with hurlers and a lot of inborn errors of metabolism if they are too many in number and in the wrong place. Usually we get it in the area of the sacrum, but if you find it elsewhere, it could be a problem. And the last one is we discussed about convulsions with respiratory distress, like a bronchiolitis like picture, and we discussed calcium. What is the other thing that can cause convulsions?
Magnesium.
Hypomagnesemia.
Okay. Hyponatremia. Okay, hyponatremia is very common. Huh? That is the first common cause of convulsion in a bronchiolitis, because we are always tuned for calcium.
In this child, knee jerk are brusque, so should we opt for the atlantoaxial imaging study?
See, in a routine situation, you will not look for it, okay, unless there is some symptomatology. Yes, the associations are well known. So to that extent, I don't think a routine screening only for two things, a thyroid and a heart. That's a routine screening. Rest of it we know, there could be many things. Like if you trace them further, they are known to get Alzheimer's very early in life. Okay, but those are all few. They are likely to get leukemia or a testicular tumors. That also a little later. So there is no need of screening routinely except these two, a thyroid and that, simply because the association is so common.
It is the hypotonia, sir. Yeah. The ligament laxity which is responsible for this, for the dislocation of the hip, and even for an undescended testes, which is pretty common, the gubernaculum. So it's all the hypotonia which is related to it.
And of course you could consider a hearing test. Hearing impairment are also known. Visual. So I think to any developmental delay, vision and hearing must be tested, because you can't make it clinically so well. And in this child, a thyroid and a heart. Could it have been prevented? What's the mother's age?
30.
30. So is 30 a risk? Then what's the risk of Downs in a general community? What's the risk related to maternal age? You get the question?
Take the mic.
1:1000 in general community. 1:750 about 25 years, 30 years, about 30 years, and 1:40 about 35 years.
40.
I feel Downs is very common, 1 in 1000.
General is 1:1000.
And if you go beyond 35, it becomes even 1 in 200. So that's the important age. Paternal age is a little higher. Maternal age about 35. And I think that would be the way to.
So the anomaly scan is very important before 20 weeks. So you have a femur length, you have the nasal bones, you have the gas pattern in the abdomen, all which have markers. I mean, you have a marking system for it, which I can't say of this thing. So that should be linked with the maternal screening.
How do you diagnose, how do you suspect prenatally?
Sir, antenatally, first of all, the age of the mother. Then in first trimester, we on ultrasound, nuchal translucency is being checked. Along with that, we could do a metabolic screen of beta HCG, PA, PPA, and beta HCG. Then in second trimester, around 16 weeks, there is a triple screen, beta HCG, alpha fetoprotein and estradiol, and a quad screen along with all these three, inhibin is added. So it around, quad screen gives around 90% of, 80 to 90% diagnosis of Downs on ultrasound.
Also consider invasive test and non-invasive test. Non-invasive test has a false positivity to about 5%. Invasive test has a risk of 1% of even fetal loss. So you'll have to weigh between all that. Okay. Have you heard about a familial Downs? What is familial Downs? Obviously what I meant was that the Downs female has given birth to a Downs child. That is familial Downs. Is that possible?
Translocation 21-21 is 100% chance of.
Very good. Okay, that's also possible. Males are invariably infertile, but the females could bear a child. And then she could have a 50% chance of producing a Down's baby. So, happens rarely, surely, but yes, that is where a translocation has a risk of a female translocation could bear a baby who's 50% chance of producing a Down. Lastly, would you do a Down screening on every pregnant mother?
No, sir. Only in
It's 1 in 1,000. Today, 1 in 2,500 hypothyroid screen for everyone. 1 in 2,500 or 1 in 3,000. Now this is 1 in 1,000. So what do you think? Should we do regular screening?
Sir, in
As a rule, antenatal screening should be to follow all the mother, and if there is suspicion during the antenatal screening, then we will screen for that mother for the further investigation.
See, time has come that prenatal screening is normal, and I think looking for all this is a routine now. In high risk situation, of course, today every maternity patient goes through ultrasound. Why should they not look at whatever? I may not do all the biochemical tests, but there are enough ultrasound markers to suspect. So today is the situation where even a routine pregnancy needs to be, because it's not that just the age, at any age. And it is kind of easy to consider the probability. If you pick up, then of course you can do all the metabolic tests that she talked of. Yeah. What's the prognosis of this child? Prognosis for life, prognosis for intelligence, prognosis for quality of life. Not difficult.
Sir, for life, he may live up to 50 to 55 years, and as days goes on, there are more chances of complications such as leukemia as well as Alzheimer's disease. And for the cognitive wise, I mean, child is most likely mentally retarded, cognitive impairment, and but they are very happy child. So I would like to counsel about the peculiarities of this child and what they get positive out of the child. I mean, playful and happy child.
Generally, you would say that if there is no significant other defects, then the child will lead a quantity-wise a normal life. But by intelligence, he will never be normal. A typical Downs could have 60, 70 IQ as an adult. Okay. You don't feel so bad to begin with because your brain is not much tested. So they go through initial school days, lag a little behind, but as they become adult, they are quite behind. And they're about 60, 70 IQ. And depends on the rest of the thing. Lastly, before we stop this, somebody come here and counsel.
By the time somebody comes in, Dr. Mahesh Mohite has added that atlantoaxial dislocation is about 1% incidence in Downs and subluxation about 15% in Downs.
Oh, so it's that common. Any hypertonic child will have all that. Okay. Any lower motor neuron paralytic child also has that. So look at hypertonia as a feature of all that. Yeah. Come, one of you come.
Sleep disorders. Sleep disorders. They have hypotonia. Obstructive sleep apnea is extremely common. So that itself contributes to cardiac morbidity. You develop a PHT, a pulmonary hypertension, and a right-sided cardiac problems.
Also, that's a very common and probably a hidden cause. Obstructive sleep apnea. But why should it occur? Do you think hypotonia? What hypotonia? Peripheral hypotonia. So why should the Downs have obstructives? Where is an obstruction? There is no obstruction. Falling off the tongue. Okay, comparatively the mouth is small and the tongue is large and tongue falls back, especially in sleep, and you have an obstructive sleep apnea with pulmonary hypertension and a heart obesity.
Plus obesity. Obesity. Never forget the obese part of it.
Tushar, you were saying?
Yeah, and I was just saying this that all Down children, you should be careful when you take them up for any procedures. Okay, because right from, as Sridhar said, intubation where you have to take care, take care for atlantoaxial dislocation, to their hypersensitivity to many anesthetic drugs, to their reversal and coming out is also delayed because of the falling of the tongue and for hypotonia and large tongue, etc. So all
Absolutely.
those have to be taken into account.
In fact, quite a few times the Downs at birth need resuscitation. And then there is a delayed development. So you would say, oh, there was a hypoxic ischemic injury, he needed resuscitation, bag and mask, oxygenation, and now he is delayed. So how will you in that case differentiate whether the delay is the Downs delay or it's a hypoxic ischemic encephalopathy causing delay? You get my question? Quite many times Downs need a resuscitation. Again, because of the same situation.
So what are the signs in a HI child as the child goes along? Signs, clinical signs.
Spasticity.
Very good, spasticity.
So cerebral palsy, okay, spasticity, okay, these children are hypotonic. So somebody quickly counsel before we go to our next case. Yeah,
Commonly this question asked is, what happens to Downs who develops hypoxic ischemic encephalopathy?
I think the hypotonia is never a feature of an hypoxic ischemic encephalopathy. Hypotonic CP is a given up term. Hypotonic CP is a very severely retarded child, and that is because all connections from higher cortex to lower centers are all disturbed. Therefore, corticocerebellar, for example, will produce hypotonia. So hypotonic CP is almost a misnomer. If you have got a severely retarded child, yes, who is a hypotonic, one could consider that. So by and large, even that child would show some spasticity. Okay, and therefore that would be. But a good question, how can a hypotonic child demonstrate spasticity? And I suppose that is what it is. Again, these children are not so severe. Hypotonic CP is almost a zero development. And therefore one wonders whether it is a CP at all. Hypoxic ischemic injuries are not devastating all over. Okay. They pick up some areas. They pick up some scattered areas, but not completely scattering all connection from cortex down. So to that extent, yes, that is the way it is. Right? Somebody quickly counsel in 5 minutes, we move to the next case. Come. You are all taking for granted you will pass. That's a very encouraging thing, but still you may practice, doesn't matter. Yeah.
Even
Come,
Tendulkar
come.
needs net practice.
Come. So, one of you. Unless I close my eyes and point a finger, then you come.
So shall
Come
I
on.
counsel?
Yeah, she wants to counsel.
Come. Very good. Come. Yeah, counsel him. He will ask you funny questions. Yeah. Come, take this mic.
आपको पता है आपके बच्चे को क्या है?
नहीं, आप बताइए.
अच्छा, आपको
So first step, first you introduce yourself. मैं डॉक्टर so and so, Hindi, English, all that.
Don't ask him whether he knows. He is not supposed to know.
Okay. मेरा नाम डॉक्टर रेशमा है, मैं आपके बच्चे की डॉक्टर हूँ. आपको बच्चे को जो बीमारी है उसके बारे में आपको बताना है. तो आपको कुछ भी जानकारी है बच्चे की बीमारी के बारे में?
नहीं डॉक्टर साहब.
ओके. आपका पहला बच्चा है?
हाँ.
ओके. देखो, इस बच्चे को एक अलग बीमारी है जिसको डाउन सिंड्रोम कहते हैं. ये अनुवांशिक होती है, मतलब अंदर अपने शरीर में जो पेशी होते हैं उसमें जो सेल होते हैं उसके अंदर कुछ तो प्रॉब्लम हो गया है, उसकी वजह से ये बीमारी होती है. इसमें माता पिता का दोष नहीं है, ये अपने आप कोई भी किसी भी बच्चे को हो सकती है. तो ये आपके बच्चे को हुई है. ऐसे बच्चे को हम स्पेशल चाइल्ड कहते हैं, स्पेशल बच्चे कहलाते हैं. इनमें प्रॉब्लम ये होता
इसमें
है,
स्पेशल क्या है?
आप ठीक है, ऐसा आपको लगता होगा कि आपका बच्चा बहुत बीमार है, पर हमारे नज़रिए से वो स्पेशल है क्योंकि उसमें वो दिमाग से कमज़ोर होगा, क्योंकि उसमें समझना, पढ़ना लिखना ये थोड़ा धीरे में से गेन करेगा बाकी सब बच्चों के हिसाब से। पर वो घुलना मिलना, लोगों से बात करना, ये सब चीज़ें में ज़्यादा एक्टिव रहेगा। जैसे कि गाना है, सोशल एक्टिविटी है, उस सब में वो ज़्यादा एक्टिव होगा। मेडिकली देखा जाए तो इसमें प्रॉब्लम्स है, काफ़ी सारे प्रॉब्लम आते हैं। ज़रूरी नहीं हर बच्चे को सारे प्रॉब्लम हो, इस बीमारी में बहुत सारे प्रॉब्लम्स होते हैं। तो आपके बच्चे के लिए हमको हर 6 महीने या 1 साल में आके तपास करना पड़ेगा कि आँख का, कान का, हार्ट का, कि देखने के लिए कि प्रॉब्लम हो रहा है या नहीं। ज़रूरी नहीं कि हो, पर जितना जल्दी आप आएंगे बार बार दिखाने के लिए तो जल्दी ये मतलब पता चल सकता है कि कुछ प्रॉब्लम है या नहीं।
लेकिन डॉक्टर साहब मुझे कुछ समझ में नहीं आया मुझे कुछ समझ में नहीं आया कि मेरे बच्चे को प्रॉब्लम क्या है और मेरा बच्चा अच्छा हो जाएगा कि नहीं।
आपका बच्चा बुरा है ही नहीं, वो अच्छा ही है।
Okay, so I think I wanted to give you a chance to speak, so I allowed you to speak, but I think the focus of counseling is a little different. So you should not be dwelling on the lines which you dwelled. So we've discussed this many times. First is a simple explanation of the disease, as simple as possible. Okay. Second, the questions which sir asked just now. Is there an immediate threat to life? That's the second thing that you do in counseling. Okay. Now don't talk of कि इसमें बहुत सारी problems हो सकती है, हम देखेंगे. Then it is endless. Just talk of the present things. Give the big broad picture. So you want to say that development will be a little slower than normal. Now how slow even you don't know just now. So how can you predict? So you say that we'll follow up and see how it goes. So just now just sensitize that development will be slower than normal. Today there are no major medical problems and that's it. Okay, I don't think you should go beyond.
Absolutely. I think what you would have said is that this child is unfortunately born with a small defect. Okay, all organs are there, but they are growing little slowly. This happens in fetal life and it's just an accident. Like any manufacturing equipment sometimes has some minor defect. So this is what unfortunately happened to your child. But all organs are in place and they are all working. But yes, brain is working slowly, but it will catch up. He will start walking, but he may walk a little later than usual. But once he starts walking at 1.5 or 2 years, he will walk as fast as anybody who started at 1 year. So she should know that ठीक है थोड़ा देरी हो जाएगा मगर बाकी तो भागेगा. It's not that you started walking late so now you will always walk slowly. No. So she says okay ठीक है थोड़ी देर. Then you say normally also sometimes not every child walks at 10 or 12 months. Some children walk at 15 months. Some may start walking at 10 months. These are all normal variations. And your child is likely to be on the later side than on the earlier side. He will talk, but he may start talking slowly. Okay. He will walk, he will run, he will go to school. Don't worry. As the time goes, we will see how he is progressing and we will help him to progress. Yeah, that's also important. Now I come on his physiotherapy, his stimulation. Okay. And I think make that. After all, this is again a developmental delay. So you talk in terms of same thing. And early stimulation. What is early stimulation? Fetal, neonatal, infant, toddler. What is early? You use the word, no? Early stimulation. What is early?
Because before 6 months, because of
the point is that when the brain is growing fast, it can grasp fast. So the brain is growing fast in the first 3 months, first 6 months, first 1 year. It slows down. So early is as early you see the child, if possible in the first 3 months. Because that's the time the brain is growing fast. And I think that is early. If somebody came at 3 years, there is nothing early now left. You will still try because the brain still continues to grow till 5 years, but majority of the growth is already over. So early in a growing phase, what is the fastest growing phase in the first 3 months? Next fastest, the next 3 months. Thereafter, the next fastest, next 6 months. By the time a year has gone, a lot of brain growth has already occurred. That's the time the brain can grasp a great deal. And I think that is early stimulation. So this child needs an early stimulation. Okay, and what is early stimulation? Give him an incentive to function. Okay, don't wait for him to learn, but make him learn.
Because of dendritic pronation and neuronoplasty.
Yes, that's exactly the word to be used. Okay, the brain is easily moldable. Okay, not only that, if one area is not functioning, adjoining area has an ability to take over that function. And that all happens in a growing stage. That is neuronal plasticity. Okay, and I think that is what you would do. Can we go to the next slide? Yeah. Yeah, somebody has some question. Take the mic.
So when do we arrange for a first counseling session? Suppose we come across a baby at birth and we suspecting trisomy 21. So when do we arrange a first counseling session for the parents?
I think if you are sure of, see, Downs can be diagnosed as the head comes out. It could be nearly confirmed as you see hypotonia. So you are nearly sure. You don't have to announce to say, I think your baby is going to be delayed, etc. But you could say that I see some different features on the face and I feel that the tone of the muscles is also low. I think I would be happy if we do some tests and see why that has happened. Okay, that would be my first way. Then they would ask, oh, are you worried? No, I'm not worried. But normally this is not the kind of face I can see all your relatives, none of them have this face. And then he is a bit hypertonic. So it is better that we do some tests and we will find out how early we can help the child. I think that would be my first. Never give a diagnosis on the first meeting, but give them a clue that we want to do something. Consider that you have diagnosed leukemia. Don't say, oh, it's a blood cancer. No. I would say that your child is looking rather very pale, but you have been nourishing him well. So I'm worried. Why, in spite of good nutrition, your child is so pale? So either the nutrition is not getting absorbed maybe, or it's not getting utilized maybe, or the blood is not forming maybe, or the blood is getting destroyed maybe. I'm not sure. Let me examine the blood. So I know that it's a Fanconi's and it's an aplastic anemia. Okay. But the way I put it is, you are nourishing well, no? Why are you pale? Maybe you are not absorbing. So give them all 4 causes likely so that they don't start suspecting. Then they would say, I hope it's not serious. No, we even don't know. It could be something very simple. But let's do the blood test. So initially, they should not get a shock of their life and say, oh, this could be leukemia. I think we'll do a bone marrow. No. I think that's the way counseling.
So parents rejecting that baby is not an issue. Parents rejecting the baby shouldn't be a cause of concern if we tell them at the first go ki the child doesn't have a prospects of normal development.
There will be implications of you telling them. There will be implications of you telling them, but you can't afford to not tell them. So therefore you will have to tell them in a little milder way.
Rejection can happen anytime. Anybody can reject anybody. Okay. Our job is to make this as human and as sensitive as possible, and definitely, as Rajesh said, there are medical legal implications of missing a diagnosis as well.
Exactly.
So hence your doubt should be conveyed and put on paper. Thank you, doctor. Can we go on to the next case?
It was a good presentation.
Yeah.
Good presentation and appreciation.
Very good.
Good evening. My patient Anj Gautam is a 2-year-old male child, first by birth order, born of non-consanguineous marriage, Hindu by religion and Gautam by community, resident of Vadala and hailing from Kanpur. He was brought by an informant being mother with chief complaints of fever since 8 days, pallor noticed by the mother since 8 days, and decreased activity since 4 to 5 days.
The child was apparently alright 8 days back when he developed fever which was acute in onset, high grade, not associated with rigors or rash, no diurnal variation, responding temporarily to medication, with the child being less active even during the interfebrile period. The mother has noticed pallor over the past 8 days, which has progressed over this duration. The mother has noticed less activity and playfulness in the past 4 to 5 days, with also history of decreased feeding. There is no history of cough, cold, breathlessness, no history of ear discharge, vomiting, convulsions, no history of excessive crying during micturition, no history of loose stools. There is a history of passage of worms in stool 15 days back. There is no history of passage of high colored urine or yellowish discoloration of the eyes, no history of swelling over the feet or decreased urine output, no history of eating of non-nutritive substances like mud or chalk, no history of bleeding from any side, no history of abdominal distension or mass in the abdomen, no history of pain or swelling of joints or limbs, no history of blood transfusions in the past or in any family member, no history of jaundice in the past, no history of tuberculosis or tuberculosis contact. Family history is not significant. Going on to the birth history, the mother was antenatally registered at the 4th month, immunized with 2 TT injections, was advised supplements but was non-compliant with the supplements. There was no history of antenatal fever or rash, no history of hypertension, diabetes or any other complicating factors. It was a full-term caesarean delivery due to transverse lie. The baby cried immediately after birth, had a birth weight of 2.5 kg. There is no history of neonatal jaundice or blood transfusions in the neonatal period. The child is completely immunized up to 1.5 years of age according to the national immunization schedule, and no special vaccines were given. The child is developmentally appropriate for age. In the dietary history, the child consumes a mixed diet with consumption of non-vegetarian diet twice a week. He has a deficit of 400 calories and a deficit of 5 gram protein. Socioeconomic history wise, according to the modified Kupuswamy scale, it comes into lower middle class.
So what is your analysis of the fever? Since we have about half an hour only, we'll go a little faster. So what is your analysis of the fever?
It's an acute onset fever, high grade.
So what does it suggest? It suggests an infection.
It suggests an infection.
What kind of an infection?
It could either be a bacterial infection or a parasitic infection.
Okay. So why do you say bacterial and why do you think it could be parasitic as well? You're sure it's not viral?
It could be either of that. It could be bacterial, viral or parasitic because it's a high grade fever.
No, so when we take the history, we are supposed to try and put one ahead of the others, no? So out of the viral, bacterial, parasitic, would you like to put an order? What is most likely? From the features that you have elicited in the history. You've told us that. What do you think?
Generally.
So your history suggested that this is a bacterial infection because the child is sick, interfebrile, etc., etc. Okay? Okay, then how do you correlate the pallor to that? So talk about the pallor, talk about your thought process.
The pallor has been noticed by the mother since the last 8 to 10 days. It would suggest that the anemia is related to the fever or has been precipitated by the acute infection.
Okay.
It could be an acute hemolysis which has been precipitated by some infection.
Okay, so what is there in the history or not there in the history to favor or, doesn't fit with this?
Icterus, jaundice, no history of jaundice.
Okay, then? So can this be deficiency anemia? 2-year-old, no, very common. 2-year-old can be deficiency anemia. Sudden onset nahi, it is because of the fever the mother noticed. Child was always pale. Now because fever came in, the mother has noticed more. So someone is asking how is the growth of the baby? Means not parameters wise, mother's judgment of growth.
The growth and development of the child is normal according to the mother.
So does that bring in deficiency or rule out deficiency? What nonsense. How can normal growth rule out deficiency anemia? Deficiency anemia, iron deficiency anemia need not affect growth of the child, no. The specific nutrient deficiency does not affect overall growth. So growth is not meant for that. Growth is meant for systemic chronic disorder. So you say hemolytic anemia, congenital hemolytic anemia is less likely, okay, we'll agree. Okay. So how will you judge whether this is iron deficiency or no?
In history, she said there is no history of any pica and all that.
All iron deficiency need not have pica, no? What sir just now said, no, in an example of counseling, so diet is important, no? So does the diet sound like it is iron deficient?
No.
Is he a milk addicted baby? You said 2 times non-vegetarian, eats the normal food. So when the diet does not sound like iron deficient, then that is your strong point that look, I am not suspecting deficiency to begin with. Then of course it has happened with fever, the pallor is noticed and all that, that adds on. Okay. What about bone marrow problems? So we discussed deficiency, we discussed hemolytic. What about bone marrow problems? Could this be a bone marrow issue? Child is sick, no? Child is sick.
We have to consider all cell lines in a bone marrow problem.
So 2 are already there. Third we'll find out on exam.
So this is acute in onset and not associated with acute in onset, no weight loss, and not associated with low grade fever for a longer time.
So bone marrow problems come with weight loss and all. Bone marrow problems in children can be acute, no? Leukemias are acute, always a short history, not a very long history.
And associated like petechiae and skin rashes are not there, and recurrent of infection, bleeding are also associated with acute.
Infection is there, no, just now.
But just one episodes, I mean, not.
Any other thoughts, anybody?
Bone pain.
Bone pain, yeah, okay.
Acute onset triggering anemia could be a bone marrow. If clinically we are having a 2 cell line, it is almost considered that child may have a 3 cell line affected. Clinically we get usually 2 cell line.
So from this much information, bone marrow cannot be ruled out. But again, so what is very important is, was this child absolutely alright 8 days back? It's a 7-day history, no? So 8 days back, if this child was absolutely alright, dancing, playing, no complaints at all, that kind of a history is very important to decide whether something was brewing up over some time or it's really a 8-day story, right?
I think 2 issues. One is fever for 8 days. Now, what has happened to fever over 8 days? Why do we call it a bacterial infection? Bacterial infections are of 2 types. One which localizes right away at the onset, like a tonsillitis, bacillary dysentery, UTI, where the symptoms come very early. Okay. Another is symptoms localize over the next 3-4 days. Look at pneumonia. By day 3, you must know pneumonia. By meningitis, you must know by day 3. Which infection is waiting for 8 days for you to wait and localize? So, as the fever continues for 8 days, and if there are no other symptoms, forget pallor for a while, then it's very likely it's not an infection at all. Okay, what infection starts as high fever and stays for 8 days without any significant symptoms? Yes, there could be typhoid, not commonly at this age. There could be TB, not just high fever at the onset for 8 days, There could be an SBE on a heart disease, yes, but there has to be something wrong prior. So when you are looking at 8 days of a bacterial infection, you are looking at an hidden site of infection, like a typhoid or like a TB. And TB doesn't hide with high fever for 8 days. In fact, typical pleural effusion of TB is a high fever and localizes very early. So then this may not be a bacterial infection at all. In fact, as you go beyond a week or so without localization, and of course without treatment, then you are almost away from infection. Except, of course, as I said, typhoid, this, that. You keep in mind, not at 2 So this may not be infection at all. So that's my first comment. Second is, it's very unlikely that fever makes the parent notice anemia. In fact, in fever, they look much more flushed. Why are they looking at anemia now? Okay, not a common feature. Again, what's the socioeconomic background? How many children? Is the mother primary, doesn't know, coming from a very low socioeconomic group, has no time to look at for her other course of life? Yes. Otherwise, why should a mother miss that anemia and bring it out only on fever? And as Rajesh said, that we must know how well this child was. It's not difficult to make out on history. Most important is behavior. At 2 years, how is he behaving? Is he happy running about? Or he's always whinging, crying, irritable? It means that he is not normal. Is he growing well according to mother? Maybe compared to other children or whatever? That will tell you whether they. Is he eating well? Okay, what are his eating habits? You said 400 calories less, etc. Now he's a 2-year-old. So he should get 1100 calories. He's getting only 700. How is he getting 700? Is he eating everything well? So, and lastly, has his milestones always been normal? He's a normal child. If he's a malnourished child, his motor milestones are getting delayed. I would like to know when he started standing, when he started running. It could be that he stood at 10 months or 12 months, but thereafter he walked only at 16, 18 months. Oh, something happened during that time. I would know with the milestones, especially the motor milestone. I will guess that this child was not all right. So first I want to know whether this is a chronic anemia or an acute anemia. How does acute anemia present? Either with shock or with cardiac failure. This child didn't do either of the two. So this must be chronic anemia. It's a chronic compensated anemia. What are chronic anemias? Largely deficiency or hemolytic. Chronic bone marrow? Yes, possible. Okay, for example, a myelofibrosis, osteopetrosis, they are chronic. Osteopetrosis is a chronic anemia. Okay, and still a bone marrow anemia. But less likely, less common. So then it must be chronic deficiency or a chronic hemolytic. What is chronic hemolytic? Oh, happy child otherwise, but not growing. So stunted, family history, etc. Abdominal distension, you said no. No abdominal
The
The
distension.
mother did not notice, given a history of abdominal distension.
Yeah. And therefore, chronic hemolytic unlikely. So why not settle for chronic deficiency only with the history like that? But if you convince us that he was growing well till a week ago, okay, he was happy, he was running about, he was eating well, and now he gets fever and pallor, then of course it's a bone marrow disease. Now considering the commonness is a deficiency anyway. So I want to pick up deficiency. He is low in calories, so he must be deficient in not only iron or B12, whatever, he must be deficient in many. What's the hallmark of a deficient child? Calorie. He is irritable, he is ever hungry. Is he ever hungry, irritable child? And if it's a protein, then is he a dull child, apathetic child, not interested? So I think try to pick up all that. I think that would be the way to go back. Yeah.
Again, two volunteers to examine quickly.
General examination from a distance also. That way. Yeah. So, from a distant general examination, okay. In lieu of anemia, fever, etc. So, where are all mics hidden?
Lethargic, looking lethargic child, disinterested, and hypopigmented lusterless hair, and sallow complexion, and apart from that, what? Pallor is there, and there is some post-inflammatory markings on both limbs, and apart from that, hyperpigmented knuckles, and
Go on.
and looks slightly tachypnic at present, and
What about growth, abdominal distension?
abdominal distension is there, more in upper part it looks like, and that's all.
What about hemolytic faces?
No. Not look
So
like
no
hemolytic
hemolytic faces. Okay.
No signs of
So
deficiencies
what's your bet?
at present.
What's your bet? Looks sick.
Looks
child.
sick.
Has an abdominal distension and a mildly tachypnic. In the history that is given, what's your best bet now? So we are away from just the deficiency anemia. He's sick. He's got an abdominal distension. So now you move away from deficiency anemia. What must that be?
So bone marrow is a possibility.
Bone marrow aplasia or bone marrow infiltration?
Yeah. Infiltration.
Infiltration, because in aplasia there is no hepatosplenomegaly. In this child there is abdominal distension, so, and very sick child with high grade fever and acute onset of the pallor.
So now tell me, sick looking infiltrative bone marrow anemias versus not sick looking bone marrow infiltration. So we'll divide between sick and not sick. Bone marrow infiltration, yes. Sick and non-sick. He's sick. So non-sick will be out. Which are non-sick?
Histiocytosis.
Histiocytosis?
No.
Maybe generally sick. So let's
Myelofibrosis.
Myelofibrosis is also sick.
Lymphoma.
Lymphoma is sick.
Osteopetrosis.
Storage
disorder, osteopetrosis.
Storage disorder. Okay. And one of the storage is osteopetrosis. Okay, it's a storage. So storage disorder. So this is not storage. That much we knew.
Yeah.
Okay. So sick looking bone marrow infiltrative disease. Now which one of them may have lymph nodes? So we'll look for lymph nodes. If they're not there, then we'll say less likely. So which are lymph node with bone marrow infiltration and sickness?
Lymphomas, leukemias.
Yes, so histiocytosis, lymphomas, leukemias, all right. So which one of these come in a short period? Lymphoma, histiocytosis or leukemia? Leukemia. Lymphoma will take time to develop severe anemia, liver and spleen. So probably not. Okay. Which ones are without lymph nodes? So leukemia could be still without lymph nodes, yes.
Histiocytosis.
Myelofibrosis, etc. Yes. Okay. So that's what it is. So now come somebody and examine. So we could make out a lot, right? We could say bone marrow infiltration. We could say.
So just that mention about hyperpigmented knuckles, which I keep stressing on.
So hyperpigmented knuckles. So B12. Okay, B12 with sickness and liver and spleen, what we look at from a distance.
Megaloblastic anemia can also present with splenomegaly, hypersplenism, pancytopenia.
Yeah, but will it present with hepatosplenomegaly and abdominal distension?
Not so.
You see a hyperpigmented knuckle in the first year, always look at the mother. Whether she's got vitiligo, whether she's got pernicious. I mean, the mother has less deposits, the child is a vegetarian and then he gets it. That's the way it is. I don't think there's so much of importance to be given to a hyperpigmented knuckle.
I think more than just the hyperpigmented knuckles, the general skin pigmentation. Yes, that will be a B12 or of course the adrenal disease. But not just the pigmentation. Okay.
दिख रहा है क्या चेयर? हाँ भैया, कैमरा में आ रहा है. Will he cry? इधर सुलाएंगे तो रोएगा. अच्छा, ठीक है. थोड़ा सा ऐसे घुमा दो बच्चे को. हाँ, ऐसे बिठा दो. हाँ हाँ, और थोड़ा ऐसे. हाँ, बस.
On inspection of abdominal, abdomen is distended with umbilical stretch.
Just quickly tell us the positive findings and then we can.
With no flanks fullness. No dilated veins or scar marks. No any sinuses.
Meanwhile, you tell us the anthropometry.
The weight of the child is 9.36 kilograms, which falls between the -3 to -2 standard deviation. The length is 84 centimeter, which falls between -2 to -1 standard deviation. The weight for length falls between -3 to -2 standard deviation. Head circumference is 48 centimeters, chest circumference 49 centimeters, and a mid-arm circumference of 13.5 centimeters.
On general examination, any findings other than what they mentioned?
The child has pedal edema, extending up to the ankles, spitting in time.
Sir, on inspection of the abdomen looks distended, with upper part of the abdomen looks more distended than the lower. Umbilicus is pushed down, slightly everted, flanks are free. There is no scar, sinuses or dilated veins. On palpation, superficial palpation, the skin is normal in temperature and there is no tenderness on palpating from anti-clockwise. And deep palpation, liver is palpable approximately 2 to 3 centimeters below the right costal margin in the mid-clavicular line. Spleen is, there is a massive splenomegaly around 5 to 6 centimeters approximately below the left costal margin in the splenic axis. Notch I could not palpate. I cannot feel the notch, sir. And span.
Is the liver firm in consistency?
No.
What do you think?
The liver is firm in consistency.
Spleen is hard, sir.
Okay. Fine. And just confirm the pedal edema. Is there edema?
Swelling is there.
Okay. Fine. So now tell us what do you think of the findings in general. Discuss what do you think. What are the possibilities? Okay, discuss the differentials. We got 5-10 minutes quickly. So has examination contributed? What have we got?
There is hepatosplenomegaly. More.
Sir, it's more of a splenohepatomegaly.
Okay.
Spleen, massive spleen, and firm spleen is there.
Fine. So now tell us what do you think?
Leukemia or lymphoma?
So did you get any signs, any petechial spots, any lymph nodes, any bony tenderness?
Lymph nodes are not there.
Does that splenohepatomegaly tell you something? You said it's not hepatospleno. Spleen is bigger than the liver. So does that tell you something? Go on quickly. What are the differentials? One differential is leukemia. What else?
Storage disorders.
What storage disorder? So will Niemann-Pick's come suddenly like this with fever of 8 days and pallor of 8 days?
But child is sick, so we already rule out the storage disorders.
Correct. So we are not thinking of storage high up.
Leukemias or lymphomas or myelofibrosis, but lymph nodes are not there. And,
Sir, infection, Kala Azar or malaria could be.
Okay, so do you think this is Kala Azar?
Disseminated tuberculosis.
So take one by one now.
Okay.
Tell us, do you think it is Kala Azar?
but in Kala-Azar, acute onset of pallor is not there.
So the illness is too short to call it Kala Azar, and then especially like we said, we didn't.
Fever is high grade and sick looking child with short duration of the illness.
So basically the duration is too short to call it Kala Azar. What else?
Endemicity also.
Yeah, endemicity. Malaria?
Malaria can be there.
Yeah, malaria is a possibility.
Yes.
But pallor, again, the.
So last time we discussed that in malaria when you
means pallor is because of the hepatopathy component of the.
pallor is not due to that. Jaundice is due to the hepatopathy, not so much due to hemolysis. Okay. Then anything else? All congenital hemolytic anemia is ruled out.
Because there is no history of blood transfusion and an acute onset fever, pallor, so congenital hemolytic anemia is ruled out. Or
No, what I mean is amongst congenital thalassemia is ruled out. But are all ruled out? Is sickle ruled out?
No.
Sickle
Is hereditary spherocytosis ruled out?
Splenomegaly and hereditary spherocytosis will have mostly isolated splenomegaly.
Okay.
Jaundice.
Okay. So thal ruled out. Hereditary spherocytosis less likely. What about sickle? Sorry? huge splenomegaly is not there. Now that's not a rule, and he's a young child, he's a 2-year-old child. So at this age, splenomegaly is possible. So that is not the point against. So there's no history of any of the crisis so far. That is a point, but just the spleen is not a point. Okay. What are your differentials?
My first differential would be malaria, considering the acute onset of illness. Second differential being disseminated tuberculosis.
Okay, why disseminated tuberculosis? He also said. Why? Substantiate it with reasons.
The hepatosplenomegaly, massive hepatosplenomegaly, and overall sick-looking child, and
yeah. So, but
generally
this. So we boil down to the same question: was this child absolutely all right 8 days back? So do you think this disseminated tuberculosis has become manifest in 8 days?
No.
So either you should have a history to substantiate that for the last 2 months he has been irritable, not doing well, not playing, etc., which tells us the illness is not 8 days but 2 months. Then you may argue. But if you are really saying 8 days illness, then you can't bring in disseminated tuberculosis. Okay? Then?
Sir, should we consider hemoglobinopathies like thalassemia intermedia which could present at this age?
Okay, so you tell me, thalassemia intermedia, what is against that?
There's no hemolytic phases.
Yeah, so I would have thought that by now there should be some hemolytic phases, because the reason why they have less transfusion requirements is that there is compensatory erythropoiesis. So that is less likely. So as we discussed, maybe sickle can't be ruled out completely, but other thals are less likely. Then?
Malignancy, leukemia.
Fine. Sir?
I think what is peculiar in this child is the behavior of this child. This child is lethargic, he is listless, but you touch this child, he is irritable. But moment you go away from this child, he is back lethargic. This is a protein deficiency. Okay. When you touch this child, he shouted, and in the next second he kept quiet again. Typical behavior of a protein deficiency encephalopathy. That on disturbance, irritable, otherwise lethargic. He's just looking listlessly. He's not responding to us. He's just awake. That's it. So definitely he has a protein deficiency. And when she said there is a pedal edema, I said yes, he has a protein deficiency. So a child with protein deficiency is likely to have also deficiency anemia. Okay. Therefore, this child has definitely a chronic deficiency anemia. But that came up suddenly with fever and a spleen. So there are two causes of anemia in this child. One is a chronic nutritional deficiency anemia with maybe calorie protein deficiency. Okay, behavior is so. Look at your first child, continuously irritable. And look at this child. Ever since she came, he's just quiet, okay, not interested in surrounding, not looking at us. Once I was talking, casually moved his eyes and gone back again. He's disinterested in surrounding. You touched him, he showed he was irritable. Classical sign of a kwashiorkor. Okay. And that has manifested with some infection. Subclinical deficiency manifesting now. So my first diagnosis is a chronic nutritional problem with malaria. Now what else could it be? Yes, you all said what it could be. That could it be some hemolytic anemia staying quietly and now kwashiorkor, etc.? Yes, likely. We can't give that. But I think what you should not miss is this child has got a deficiency. And you can see now, just listless. He's not bothered. He's 2-year-old. How can he sit there looking at this crowd and not even responding, reacting? So that's a chronic deficiency anemia with something else, with malaria as my first diagnosis, because fever. And that's what made the mother notice pallor. It was already there. and it got worse. I think that's where we stand. Rest of it would be all investigation. Eh?
Anything else that you all want to ask? Next 2 minutes.
Have any tests been done?
Sir, we have done CBC, optimal dengue. The peripheral smear has come positive for malarial parasite, P. falciparum.
P. falciparum. Okay. And CBC parameters confirm
CBC,
deficiency anemia?
It was a hypochromic microcytic picture. HB was 4.8. Normal counts and thrombocytopenia.
So this is cerebral malaria. Encephalopathy in a falciparum malaria. Cerebral malaria. Yes. Encephalopathy in a falciparum malaria. You call it cerebral malaria. This is a chronic encephalopathy, not an acute encephalopathy. Okay. So we stay with protein deficiency. I just wanted to bring out, yes, what else could it be? And falciparum malaria with a splenomegaly. I thought falciparum don't have splenomegaly or just palpable. What's your comment on that? Falciparum is all slush somewhere. There is no splenomegaly. And you have a large spleen in a falciparum malaria. Yeah, it can still occur, isn't it? Why should all of them get slush? Plus there could be a mixed also. Vivax and falciparum. Yeah.
The serum proteins are also low.
The total protein is 5.2 with albumin of 2.6.
2.6.
I think behavior is very typical of a person.
What about retic? Is retic useful? For what?
Sridhar, mic please.
If it is Kala Azar or malaria, is retic useful? 2 cell lines affected, and you have a high retic, it's malaria. And if your retic is very low, it's Kala Azar.
Anything else? Okay. I think we stop here, Tushar.
Thank you, everybody. This is good. Thank you, everybody. We conclude today's session and we meet again next Thursday, 6 o'clock from Sion Hospital, Mumbai. Thank you.